a great honor to be here and to share these thoughts with you. I'm sure everyone in this room subscribes to the concept of evidence-based medicine. Perhaps we don't all agree with what is evidence and what evidence are we going to believe, and more importantly, is that going to make any difference to what we actually do? I, like everybody else, have been profoundly influenced by a few people in my life and in my career. And these are the two guys who've transformed my own life. One of them we know extremely well in this room, Harry, and the other, probably less well known to most of you, is a colleague called Ian Chalmers, now Sir Ian Chalmers. And I'll discuss his work in a moment. Obviously, I met Harry in 1990 when he did his first hysterectomy in England, in fact, in Europe. And we immediately formed a bond both professionally and socially. Harry is extremely effective teacher and persuader. I love this photograph of some of the team at a workshop we had. And look at the interest, almost adoration of the participants in the cadaver workshop. And this is where Harry was at his best. We worked together on producing this book, and I must say that was the beginning of the end for me in professional terms, because I went to his unit and stayed with Liz and Harry and followed his work for some days, and I was keen to get all the data about hysterectomies. And he kept doing these stupid operations on endometriosis. And I knew all about endometriosis. All I had to do is buzz the little lesions, take out the normal-looking uteruses sometimes, or the ovaries, and leave that pesky, difficult stuff behind. We used to call it burned out, or fibrotic lesions that didn't need any treatment. And I watched him one day chuck away at this for hours and tedious watching. And I said, "Why have you done this, Harry?" And he said, "Well, actually, go to the path lab." And there were 19 little pots. I recall it very clearly. And every one of these little pots, every one of these tiny little bits of useless fibrotic material that I thought actually contained endometriosis. And my comment was, I then realized that I had to start all over again and learn this surgery, this terribly difficult surgery, and start all over again. So he had this very profound effect on me. But Ian, the other guy in those photographs, Ian Chalmers, he was the guy, he and I were junior doctors together for a while. And whilst I was doing what most junior doctors do, going around trying to get experience in cases and doing stuff, Ian was always saying, "Why are you doing that? What's the evidence for this? You know how often doctors have been wrong in things." And Ian went on to found the Cochrane collaboration and really developed the concept across medicine of evidence-based medicine. He pointed out that women's health has perhaps been a victim of bad medical understanding ever since its foundation. Here's old Hippocrates here, and who could be more famous, more important in medicine than the founder of the thing? And he had this philosophical concept of the four humors, and of course, women with menorrhagia, they had blood, they were hot and moist, and therefore, what had to happen? You had to get rid of this excess humor, so you had to bleed them. And so the thought of treating heavy periods by repeated sampling of blood lasted for 2,000 years. Every respectable physician throughout the world believed and followed this. So the motto of this is, it doesn't matter how important people are, it doesn't matter how emphatic they are or where they're coming from, they've got to be right. And this was certainly not a right thing. Ian introduced me to the work of Archie Cochrane. Now, I know a lot of people think, particularly in surgical disciplines, that it's difficult or impossible to do proper studies. But Cochrane's view, on which the Cochrane Foundation is based, is that you can only really determine what is true and false by doing randomized controlled trials. Now, this concept I bought into in a big way. I did a lot of contributions to Cochrane reviews. I did 9, actually. And then I also did a lot of randomized trials. A lot of them, they're little simple ones of very early things. Learning the basic techniques of doing trials. And finished up doing this extremely large trial, a randomized trial comparing abdominal hysterectomy, vaginal hysterectomy, with laparoscopic hysterectomy, and it was 1,380 patients into 2 parallel trials. And this trial was, I'll just go back, was basically very successful. It showed what we wanted to do, that laparoscopic hysterectomy was more effective than abdominal hysterectomy in terms of pain, in terms of length of stay, in terms of quality of life. So it was good. What it also showed, so a lot of people took notice of this bit of the trial. What it also showed is that vaginal hysterectomy was better than laparoscopic hysterectomy when you could do a vaginal hysterectomy. And a lot of people didn't take any notice of that bit of the trial because it didn't fit with something or other. But anyway, those things remain true. This wasn't as well received as I hoped this trial would be, because I feel the messenger was shot, because there were actually in the laparoscopic arm 6 ureteric injuries. And because that suggested, at least at the time, that this was a dangerous procedure, a lot of people took exception to the conclusions. The reality is that these were beginners' efforts. This was what's happening across the field in the UK, and it needed improvements in techniques and technology. Anyway, that was that. I eventually started to do studies in laparoscopic hysterectomy, in endometriosis. And we did quite a long-term study of 218 over 2 to 5 years, and showed what we would hope to show, that there was an improvement in all forms of pain management with our treatments. So this was good. And then maybe the first, or certainly early on, we started to introduce quality of life indicators to measure the response to a surgery. The situation obviously being that people don't die of endometriosis, so what we're doing is to try and improve their quality of life. So these were perhaps the better markers, and we did this study, which was okay. But basically, I yearned and longed to do this study. It was my final randomized trial before I retired, and I was trying to put into this all this other experience. And this was a laparoscopic excision of endometriosis, a randomized, blinded, placebo-controlled trial. Now, these are, for anybody who's tried this in a surgical discipline, are really rather difficult to do, and there are a whole load of things. And we have to design the trial. I've learned a lot about trial design. Obviously, you've got to have the ethics approved, and I won't go into that unless somebody wants to ask about it. Equipoise, this is one of the hardest things in a surgical discipline, because you have to genuinely not know the answer before you start. You have to say, well, it might not be correct. And to get somebody who's really good at something to then say, well, I'm not sure it works. And then it's also a difficulty when dealing with patients to say, well, I'm going to give you this option or that option, and I don't know which is right, and they don't have much faith in you if you don't know what you're doing. So it's really a very difficult thing to do. Then you've got to choose the right endpoints. And this is where so many trials are a load of rubbish, because if you've got a commercial or a bias interest, if you choose the right endpoint, you will always get a positive answer. So it's not worth the paper it's written on. But if I was going to sell a robotic machines to do hysterectomies, I would always compare it with length of stay of abdominal hysterectomy or something like that. You know the answer, but it doesn't mean that this is a good idea. So you've got to choose the endpoints very carefully. And you've got to choose the power of the study. You've got to know roughly how many patients you need to prove what you want to prove. You've got to adhere to this idea. You analyze the results in the way you intended, even if you don't finish up treating this. And this is all just to avoid bias. And almost all, well, many studies, particularly in surgical things, are biased. Anyway, here we go. This is the trial we set out. It was a randomized, blinded controlled trial to compare the effectiveness of excision of endometriosis against placebo. Sorry, it doesn't work. Oh, sorry, I'm pressing the wrong button. Okay, and what we did, each patient had 2 procedures separated by 6 months, had baseline investigations, 6-month investigations, and a year assessment. And the patients either had definitive surgery at the first visit, and we did everything we could at that surgery, and then reviewed them 6 months later to measure what was left and to assess the symptoms, or we did a diagnostic and staging procedure, waited 6 months, and then took away the materials. And that was our intermediate, delayed surgical group. Now, these are, I think, self-evident. I'm not going to go into that, really. Now, we went to extraordinary levels to make sure the patients and the attendants were blinded. Obviously, the surgeon couldn't be blinded. He had to know what he was going to do. But we prevented anybody else from knowing, particularly including the patients. So the first thing is we had off-site generation of the randomization. This is very important. If you have 2 patients coming in for the day, and there's one fat one who's had previous myocardial infarction, and this other lovely slim person, then you say, well, I'll do my PET treatment on that one, and I'll do the other treatment on this one. Consciously or subconsciously, it squares the pitch completely. So you have to generate the thing in off-site, and we do that computerized. We have to use the same portals and the same approach to everybody. And we even went and sneakily put some of the patient's blood on the dressings of the portals, just so they weren't aware. The operating records were retained in a special file in the OR, and only a simple note that they were part of the trial was sent down to the ward. The operations surgeon did ward rounds and said, good morning and how are you, but took no part in any management decision. The ward medical staff and the nursing staff had no idea which procedure was undertaken. The patient gave their own analgesia. They had PCAs, so they chose how much analgesia they had, and the patient alone selected the time of discharge. This produced the perhaps expected sort of mad things. Some patients who had no treatment gave themselves loads and loads of opiates and stayed in hospital for days and days. And one very frightening patient who had the most extensive excision that we did in the series hardly had any analgesia and went home the same day. And so patient response was obviously quite interesting. So actually, I forgot to say these blobs. I chose the color of this, as you do when you're doing a talk, and I thought I quite liked the color of this. And then these blobs came up, and I thought, oh, it looks terrible. And then I thought, no, actually, this talk is about a messy endpoint to what was started out as a good thing. So this is the good bit. These are the results that we published, and I'm not going into this very much, that basically we showed that immediate surgery produced a much greater relief of symptoms than the placebo. Really nice, a lot of noughts and clinical significance. That was good. And there were 12 people in the series who wanted pregnancy, 6 people after operation had it, and none of the patients who prior to surgery got pregnant. So we're happy that we made the thing. And so this was pain. If we looked at pain scores in both groups before and then 12 months after, there's a satisfactory response. And there was no long-term problem about whether the patients had primary or delayed surgery. So we concluded that laparoscopic excision was more effective than placebo in reducing pain and improving quality of life. Hurrah! That's what we wrote up. That was a job done. But this relied on a simple idea of medicine, that you make a diagnosis, and we've heard how difficult that is. We do the treatment, and we've certainly continued to hear how difficult this is. But then we expect a cure. And we've reported this very much as this sort of study. But the problem with having too much time on your hands when you retire is that you can look back at these things in more detail and a less driven way. And I call this now the messy bit of this trial, because we went back to the results and looked at and found some interesting or different things. Perhaps not surprisingly, there was no difference in the groups of analgesia required between those who had major surgery and those who had a diagnostic procedure. Anesthetic use was the same. Perhaps not surprising, because the entry is the most painful bit of it. Anyway, that was what we found. Similarly, no difference in length of stay, no difference in length of medication and treatments. So there was no difference in this study between. And these facts are all well known. The severity of pain was not correlated with the severity of the disease. There was pain without endometriosis in some patients and endometriosis without pain in others. So this is all, again, well known. Now, what's the matter with this slide? If we looked at 6 months, we get, in the delayed group, we get some improvement in the symptoms. Now, this is not surprising. Placebo effect is well known. And so this was an improvement in the placebo. But this was a surprise. This was the people who had an immediate operation, and they were better. Their pain score was better at 6 months than it was. But after a further 6 months, when they had no further treatment, their pain score got better. And this was true whether we looked at pain for non-menstrual pain, whether we looked for pain with dyspareunia, whether we looked for pain with dyschezia. And the only, of all the measurements we took, the only one that did what it was supposed to do was this particular quality of life measure, Euroqual 5D, where the delayed surgery stayed the same while there was an improvement in the immediate surgery. But at the end of the day, they caught up again. So what does this mean? What's going? Even, this is more quality of life, this is short form 12, similar changes. Short form, the mental component, similar, whether you had the operation or not. And even sexual activity. How can this be that both of them had an improvement from baseline, whether they had the surgery or not? There was a further improvement after 6 months. So how can we summarize all this? Well, we can say that in the delayed surgery group, about a third of the patients reported a positive placebo response. And that is in keeping with lots and lots of other studies about this. But in the immediate group of surgery, between 6 months and a year, more than half of the patients reported further improvement. Now, making decisions without adequate information. My great country at the moment seems to have been the first known democracy to have willingly voted itself to be poorer and less effective. We're plodding on in a massively brilliant way at the moment. But part of the problem was that we didn't have enough information to make a proper decision. And the same is true about all of these quality of life and pain and all its ways that we try and assess things. What do? We've got a whole load of tick boxes or a whole load of lines to put how you feel. Now, that presupposes that all these things are constant, whereas the reality is how much pain you have or whether you feel depressed or not depends as much of what the traffic was like on the way into to the hospital that day, or whether you had a row with your husband, or whatever. Many things can alter the way. And we all now, if you buy something off the internet, within a day they will be asking you, how was our service? And you have to put somewhere down, and then they'll quote the satisfaction level and things. And this is doing stuff, making judgments. And I think because we so effectively prevented the patients knowing what would happen, they didn't know how properly to respond. They didn't want to say they were completely better in case they hadn't had the operation. And they didn't want to say they were terrifically better when they had nothing happen. So it really brings into question the validity of some of these tools that we've been using. The placebo effect is very well known, and it's quite real, and it's important. Most clinicians don't care whether it's a placebo effect or a real effect. If the patient feels better and has real benefit, then that's fine. But what I think we did with this blinding thing is we took away all the contextual clues, the verbal clues, the emotions, and so we removed some of the drivers that gave us assessment. So the power of proper blinding, we have both a positive placebo relief, this thing which I haven't seen described, perhaps people who know more about these things than I do have known about this negative placebo effect, which obviously exerts something on our outcome. Okay, moving away from the assessment, we had the opportunity to study patients 6 months after their first treatment. And we looked very carefully at this, and we found that only 31% of them had no evidence of any disease after our surgery. 25% of them had some evidence of that wasn't normal, but on biopsy, we didn't find endometriosis. And 44%, we had biopsy-proven disease. Now, I'm sure David and Harry would probably say this is entirely due to the fact we were rubbish surgeons and we didn't get rid of it all. And I think there is clearly an element in that. Clearly, some of this will be inadequate surgery. But I don't believe all of it is, and I will give you some more evidence in a moment. We also had the opportunity of watching over 6 months what happened to the group who didn't have surgery. And what we found is that 45% of them upscored, and in 3 of them, they upstaged in this 6 months. So some of them were progressing the disease quite rapidly. A third of them were unchanged, and then over 20% of them were better. They downstage. So this is a dynamic situation. We like to assume this is a fixed thing. We know what we're dealing with. But in fact, it changes over time, or it appears to change over time. So some specific cases, just to illustrate this, because these individual cases get lost when you summate things. So one patient had a stage 2 disease at first excisional surgery. 6 months later, she had a stage 4 surgery with bilateral endometriosis. So these had definitely come, and this had definitely got worse within the 6 months. And we had thought we'd excised it all in the first. So at very least, this is rapidly progressive disease, and we couldn't have missed all of that on examination. This is another patient who, normal examination, and with a very meticulous protocol, it seemed normal on pelvic examination. 6 months later, there was a large extrinsic mass, which was very easy to feel, pressing on the rectum and vagina and producing a symptomatic stricture. We could possibly have missed it on the first, but I think that's very unlikely given our thing. And so we're suggesting this is very rapid progression in this particular case. Here's another one. There's a lady who's had a lot of treatments elsewhere. She had 4 laser laparoscopies and multiple medical treatments. She came to us with stage 2 disease on the right-hand side, which was easily treated. 6 months after, she said she'd had a wonderful response for 2 months, and then it got really quite bad dyspareunia and dyschezia. And then 4 months later, at her follow-up, she found to have a full-thickness vaginal lesion on the left side of the cervix, when the original lesion had been on the right side. So again, we're suggesting that in some cases, there can be extremely rapid progress. So the dynamics of the disease, recurrence of new disease in different sites on second inspection suggested a very rapid development and progression. But disease may be due to development of new disease, and this I'm pretty sure is true. New disease are not always the result of inadequate excision. Now, we could get confused by patient's response too. Initial stage 2. 6 months later, she reported improvement in her symptoms. So she hadn't had a surgery and she felt better. After she then had the definitive surgery. 6 months later, she said she had no improvement. And 4 months after, she got fed up with us, went somewhere else, and because of worsening dysmenorrhea, they, not following the protocols, just took the uterus out and found no evidence clinically or histologically of any endometriosis. So here's a patient who got better when she didn't have an operation, and didn't get better when she had the operation, and then had an operation and didn't have the disease. So the complexities of dealing with individuals as opposed to trying to generalize into a great thing. And so there are other, you can read these things yourself. There are other cases. So my messy conclusions, instead of this lovely thing that we do excision and it just goes away and it's fine, is that our assessment tools probably aren't perfect, however hard we try. These were the best validated tools on the market at the time. Pain isn't correlated with severe lesions. Not all pain is caused by endometriotic lesions. We had a 32% positive response, 53% negative placebo response. 20% of our patients didn't respond at all. We noticed rapid recurrence and/or progression. New disease was seen, and we're suggesting not all persistent symptoms were due to inadequate excision. So this leaves us with the conclusion that there are 3 people in this equation. There is the disease, well, 3 things, the patient and the surgeon. And they all vary enormously, and they don't stay. The disease has a different dynamic. Sometimes it's static, sometimes it gets better, sometimes it rapidly gets worse. There is an invasive component. So the disease is a variable phenomenon and not just endometriosis. The patient is a variable phenomenon. That's not a nice way to describe patient, but each patient has different potential, has different characteristics. Some people have high pain tolerance, et cetera, et cetera. And of course, the surgeons vary enormously. And clearly, you want to have a Dr. Possover, Dr. Oman operate on you, and not someone who's doing 2 cases every decade of endometriosis. The surgical skills clearly make a big thing. But empathy as well. The whole of the rest of the healing process, the whole of the rest of support, encouragement, identification, and the whole team that goes with people. So at the end of the day, I think the management of endometriosis defies protocols, defies rules. It is the art of medicine. What any good doctor has always known is that you tailor your treatment for the individual patient, and the art must be built on the science but not dominated by it. Thank you very much.
Thank you.